I'm really pleased to be here today and get to share work coming from our Illinois Perinatal Quality Collaborative with all of you. I love coming to Tennessee. I've been here before. I have a real wonderful friends here and wonderful colleagues, and Brenda has come to ILPQC numerous times to share the work that all of you do across Tennessee, and you don't know it, but the work that you've done in every corner of Tennessee has inspired work that has happened in every corner of Illinois. So I just want to give a huge thank you to all of you and just kind of a round of applause to the work that's happened here. When we work together to improve outcomes for moms and babies, it has to come from a place inside, because we're all doing this work above and beyond the work we're doing every day. And so we have to find inspiration and ability to believe that we can make a change. And I believe we find that inspiration from each other. So I want to thank you all for inspiring us. And I hope some of the work that I'm going to share here today can inspire you as you go home to think we can make a difference. We can improve outcomes. It does not have to be just thinking how dire our maternal health crisis is. It can be that we can move the dial, that we can make improvements. We can focus on our mothers and babies thriving and really moving the needle on what we need to do. And I believe it starts with each of us. Today I'm going to talk just briefly a little bit about ILPQC, and then talk briefly about 3 initiatives that we've worked on. Our Mothers and Newborns Affected by Opioids initiative. I know you've done work here in Tennessee on substance use disorder and how to improve optimal care for moms and babies affected by opioid use. We'll talk about our Promoting Vaginal Birth work, which is really focused on reducing unnecessary NTSV C-sections and where we've found success and how we've done that and how we've convinced people that it can be done. And again, that's where I believe the real magic happens. It's in people believing that this work can be done is what moves us down our journey to improvement. And finally, I want to share the really important work we've done on birth equity, which is really trying to understand where our disparities come from in our maternal health crisis and understanding what are the actionable strategies that we each need to put in place on our units to improve care for all patients and to do better at what we do, which is taking care of moms and babies. So ILPQC is a statewide collaborative, just like TIPQC. We cover the state of Illinois, about 99% of births, really working on implementing data-driven, evidence-based practices to actually improve and reduce disparities for moms and babies across Illinois. Included this slide, one, because if you look closely, you'll see Brenda there, and because she's been on this journey with us. We've been working in ILPQC for 11 years, working together, engaging patients and communities. Shout out to Becca and Mama's Voices, who've also been on our journey with us. We could not do this without partnering with patients and communities for all of this work and really thinking about how we can make change happen. And I think that's where perinatal quality collaboratives and the hospital teams and the patient and family partners, we're not here just to talk about what's happened and talk about where these problems lie. We're here to make change happen. And that's what I think each of you, if you take something home from today, where can you move change to happen on your unit? Where can you move change to happen with the patients you care for and with the teams you work with? These are the initiatives we've worked on across ILPQC. We worked on hypertension to start. That was one of our real big kickoff initiatives with 112 hospitals. We worked with our opioid project, 100 hospitals. And most recently, we've been working on birth equity and promoting vaginal birth. And then we just launched an Equity and Safe Sleep in Infants, ESSE initiative, to feed off our birth equity work, which we're really excited about. And again, when you look at that infant mortality rates around safe sleep, there's really important work to be done. I'm going to start out talking about our opioid work. Opiate use disorder and pregnancy is such a crisis, and when we've separated out opioids and substance use disorder from maternal mental health in our state, in our most recent maternal mortality review committee, we found that 32% of maternal deaths in Illinois were due to overdose. So I'm going to say that again, 32% of our maternal deaths in Illinois were from overdose, and just a dramatically increasing rate of maternal deaths. And this has to do with the fentanyl that's flooding our state and every state. And so really understanding that we can make a difference for these moms with this horrible, debilitating disease of addiction, and that no one sets out to be addicted to opioids, but it is a disease that kills, and our patients with opiate use disorder are some of our most at-risk patients on our labor and delivery units. We found that we really needed to get our message across. Our obstetric providers and clinical teams had deep stigma against our patients with opiate use disorder. And also what we were seeing is that people thought this was a social work issue, that someone just needed to call DCFS and talk to this mom about her social situation, and someone needed to call neonatology and talk about NAS. And they did not see the mom at deep risk of maternal death in front of them. So we went on a campaign to re-educate our OB providers in our state. So these were the key issues we said over and over again. We made giant posters and flooded our state with them. Opiate use disorder is an urgent obstetric issue. Opiate use disorder is a life-threatening chronic disease with life-saving treatment available. There are key steps OB providers must take prenatally and on L&D to care for women with opiate use disorder, and that linking moms to medication-assisted treatment and recovery services reduces overdose deaths for moms, improves pregnancy outcomes, and increases the number of parents and babies who can stay together. So we really had to get these messages across because we realized just doing an initiative and just putting out some education wasn't enough. We had to change the way we were taking care of patients with opiate use disorder in order to save more moms' lives. We talked about what optimal care means for all pregnant and postpartum patients with OUD, screening every pregnant patient for OUD with a validated self-reported screening tool, assessing readiness to start medication-assisted treatment. And this really meant we had to really retrain our clinical teams that they could talk about treatment with opiate use disorder, and they could figure out how to link patients to treatment, and that was really vitally important to save lives. We talked a lot about Narcan. We realized that OB providers and clinical teams and emergency room providers weren't comfortable talking about Narcan, so we really had to work on that. We talked about warm handoffs and close follow-up, and then really about reducing stigma. And we found that really started with reducing stigma, promoting empathy, and talking about trauma-informed care. So what were we able to do? So this is the data. The blue is linking to recovery to medication-assisted treatment, the orange to recovery treatment services, so behavioral health treatment. And this is moms who were able to be linked to treatment either prenatally or before delivery discharge. So before that patient went home, did we have these moms linked to medication-assisted treatment? When we started out, only about 40% of the time, patients who had a diagnosis of opiate use disorder were linked to treatment before that delivery discharge, and now we've really been able to stay above 80% and sustain that into the sustainability of this project. The other thing we really worked on with all of our work, we want to look at stratified data and understand how disparities are impacting the work that we're doing in our quality improvement work. When we looked at our data on who's linked to treatment for opiate use disorder, we found a big racial disparity. Our Black patients were being linked to treatment only 23% of the time, white patients 48% of the time. That's not good enough for anyone with a life-threatening disease, right? If someone came onto our labor and delivery unit and they were in DKA, we wouldn't send them home with a phone number and say, you should try to get yourself some insulin and see how that works for you. And it's too bad you got yourself into this situation that you have diabetes, right? We wouldn't do that. We would see that person as having a life-threatening illness in front of us, and we would figure out how to get them treated, and we would manage their DKA. And that's what we need to do with our patients with opiate use disorder, who are just as much a threat of dying. So what happened? There was a disparity in who was getting linked to treatment, right? People were deciding who was going to get to treatment, who wasn't, who could, and where were their barriers, all sorts of different reasons why there's a disparity here. And what we figured out is if we worked on providing optimal care for every patient every time, what happened? We were able to reduce this disparity and improve care for all. And by the time we were in 2020, in the middle of the pandemic, we were able to significantly reduce disparities for opiate use disorder treatment. And that's something we're really, really proud of. I'm going to move on. I told you this is going to be a little bit of a whirlwind tour of our initiatives. We're very proud of the work we did on substance use disorder, and I would say that that work is ongoing. One of the things we're working on in our state is point of access. How do we improve point of access for treatment? Because so many of our, I grew up in a small town in a rural part of my state in Iowa where I grew up, and I know how hard it is to get to small community hospitals that are closing. How do you get patients treatment for substance use? How do you get treatment for mental health services? So one thing we're working on is a point of access phone number and doing telehealth buprenorphine treatment for our patients in Illinois, something that's working really well. And they can use that phone number to call and get linked to treatment 24 hours a day. So we're moving and working. We're also providing free Narcan kits to hospitals to hand out to patients in labor and delivery and emergency rooms. So the work continues for sure. The opioid crisis is not letting up. Moving on to our promoting vaginal birth work. This has been a project really focused on reducing unnecessary NTSV C-sections, improving the number of C-sections that happen that meet ACOG SMFM criteria. So when you call a failed induction, is that really meeting criteria for failed induction? When you call a second stage arrest, is that really meeting criteria for second stage arrest? Or are we just thinking, she's probably not gonna make it, and I'd really not like to do this at 2 o'clock in the morning, so why don't we just move to C-section now? So we have been working really hard to both reduce our C-section rate and also reduce disparities in our NTSV C-section rate. We have clear racial disparities in our C-section rate that we've needed to address in Illinois. So we've worked on bringing down our C-section rate at the same time of thinking about where our disparities are and how we can focus on them. So we've worked on key strategies, and what we found over and over again, that this is really culture on a labor and delivery unit. And I go out and talk to OB providers across the state, and they'll tell me over and over again that it's because their patients are sicker and their patients are more complicated and they can't reduce their C-section rate. And then what's happened is that slowly over time, most of the hospitals in the state have been able to reduce their C-section rate. And so we now have a small group of hospitals. So about, I think 48 or 50 of our hospitals have been able to reduce their C-section rate. We have 27 hospitals that are still working. But now those 27 hospitals realize it's not our patients. It's about how do we put these strategies in place? How do we get buy-in with our providers? And that has really started to move the needle for us. So what have our teams done that have been successful to do that culture? A lot of clinical team education and buy-in, unblinded provider level C-section rates, so really sharing unblinded C-section levels across hospitals. Most of our hospitals in the state now share unblinded provider level C-section rates. And I know that's in the beginning, that sounds like, how can we do that? That sounds really like we're gonna make a lot of people mad. But now it's just what people do in most of our hospitals in the state. They really share that unblinded data and able to look at how do we bring our C-section rates down together. Educating patients and shared decision-making about what to expect in labor. Cesarean decision huddles and checklists. Follow-up reviews of cases not meeting ACOG SMFM criteria, so really identifying cases that didn't meet criteria and bringing those back to OB provider meetings and having discussions about them, and a lot of labor management support. We did spinning babies for all of our labor and delivery nurses in Illinois and did a free trainings. When I walk on, I was doing a vaginal delivery Wednesday night, 2 o'clock in the morning. I was just telling Brenda. And I walk in the room and the peanut ball's going and the nurse is working with the patient and they've got extra support in there and they're talking about position changes and the nurse is telling some other nurse about what position she has her in. And I'm like, yes, it was making me so happy. It was making my heart sing. And the ACOG SMFM criteria were up on the wall thinking, and the residents were talking about how long we should let someone push and what does that mean? How do we have patience with pushing? And everyone was doing the talk and everyone was doing the walk. And I provide care in a level 3, where we bring patients in from all over to deliver on our unit. And we have a C-section rate of about 20%. These are some key resources that folks can use if they're interested in going onto our ILPQC webpage. We have a missed opportunity review that our teams really love using to pull up when they are looking at cases that didn't meet ACOG SMFM criteria to take back and share with OB providers and clinical teams to say, hey, let's look at this. You know, why didn't this meet criteria for failed induction? Why didn't this meet criteria for second stage arrest or maybe for called a failed induction? And the missed opportunity review has gone a long way to change culture because it brings conversation, it brings discussion, and it helps us all think that every case is different, and there's always going to be cases where it doesn't quite meet criteria, but it still made sense to move to C-section, but sometimes it doesn't, and those conversations are important. We have posters on the ACOG SMFM criteria that go up on labor and delivery units around our state. We stole from California's Maternal Quality Care Collaborative, their guide to unblinding provider data, and our hospital teams have loved that guide. They've used it a lot. And then we have a checklist that our teams often use in huddles and safety huddles that talk through the criteria for SMFM, ACOG criteria. And then we have a free labor management e-module that we created with a midwife in Florida, actually, who created these really wonderful spinning baby labor management e-modules, and those are available for free as well for your nursing and provider education as you'd like to use them. So what did our team say as they were working on bringing their NTSV C-section rates down across the state? This is a survey of our hospital teams directly from them, saying what did they do? And we said, what was the most utilized promoting vaginal birth strategy? Number one, 93% of our team said sharing unblinded provider level NTSV C-section rates. I never thought I would say that. The first time I talked to our teams about sharing unblinded, I thought I was gonna have fruits thrown at me, because everyone was like, we can never do that. Our providers would never, ever do it. That's horrible. How could you ever share unblinded data and just put everyone's C-section rates up on the wall in the OB provider room, or put it up during a meeting and show everyone each other's rates? That's crazy. But that's the number one strategy that's being used in Illinois right now across our hospitals. Number two was labor management strategies. Our nurses just love that. Identification of NTSV patients. This was a big one. A lot of our hospitals have bulletin boards, and they identify NTSV C-sections, and they give bracelets out with charms to nurses every time they have another NTSV vaginal birth. They have booties that go up on the bulletin board, and everyone's vying for Starbucks gift cards, and really a lot of excitement around identifying and recognizing patients who have more NTSV vaginal births. Recognition of successful NTSV C-sections, again, that's the third. They do that a lot. Cesarean decision huddles and debriefs, cesarean decision checklists, and then doing those follow-up reviews. What was the most effective PVB strategy? I'm not going to go through all of these, but I would say that each key strategy was reported as very helpful by over 50% of teams. So what that shows is these different strategies we're talking about were really used effectively across Illinois birthing hospitals. And again, that top one I think was recognition of the successful NTSV patients and really recognizing nurses and docs for successful vaginal deliveries. What strategy was utilized at improving C-sections meeting ACOG criteria? And the number one strategy was follow-up reviews, posting guidelines, checklist huddles, and provider nurse education. So at baseline, only 38% of ILPQC hospitals had an NTSV C-section rate under 23.6. And in 2023, 77% of our hospitals had achieved an NTSV C-section rate of less than 23.6 for at least one quarter. 47% of hospitals achieved an NTSV C-section rate less than 23.6. And we got up to 71% of our C-sections are now meeting ACOG SMFM criteria, which was our goal. And then finally, our ILPQC NTSV C-section rate, and this is for almost all birthing hospitals in Illinois. For 2023, the overall state C-section rate for ILPQC hospitals was 23.38%. And most excitingly, oh, I left that out. Oh, I'll put it at the end. I'm going to show it at the end of birth equity. I'll show you what we did on reducing disparities. So, and I think the reason I moved it to after the birth equity work is I think that being able to reduce the disparities in our NTSV C-section rates, it took us having lots of conversations about the why. What is driving the disparity in our NTSV C-section rates? Really thinking about our data, improving the way we look at our data, and then really partnering with patients, partnering with communities, and figuring out how to move to action, not just to look at the disparities that we were seeing, but move to action. And so that's what I want to share with you in terms of our birth equity work we've done. We really focus on moving to action. What is it that we can do on our labor and delivery units to make a difference? So this has been a really foundational initiative that builds on our existing hospital efforts to implement actionable strategies to address maternal disparities, improve patient care, and promote birth equity. We voted on this as a state to do this work alongside our Promoting Vaginal Birth initiative. We usually do one initiative at a time. And our hospitals were in a big room just like this, and they voted and said, hey, we've got to work alongside our Promoting Vaginal Birth. We need to work purposely on this birth equity work and really move to action. So we partnered with lots of patients and community groups, other states, and really thought through what were our actionable strategies. Where can we help our hospital teams move to action? And our goal by right now is to have 70% of participating hospitals have implemented all key strategies, and I'll show you how we've done so far. The 6 key strategies were optimizing race and ethnicity data collection and reviewing stratified data. So really thinking about how we collect data on race and ethnicity. How do we ask patients for their race, for self-reported race, and make sure our patients understand why we're asking and how we're going to use that information because there's such an issue of trust. So we did a lot of focus groups with patients and worked through scripts and talked about how we can ask those questions better and how we can better understand how we're doing at collecting optimal race and ethnicity data, and then how we're stratifying that data. We worked on screening all patients for social determinants of health and then linking patients to needed resources. One thing we found, and we heard about this from our patient focus groups we did across the state, was that if you're going to screen for social determinants of health, make sure that you have effective strategies and process flow to link patients to the resources and services in the communities they need. Many patients were getting asked these questions over and over again, and absolutely nothing's being done about it. It's really demoralizing to be asked those questions when no one's really effectively trying to provide help. And so we really leaned into things like findhelp.org. I heard that being mentioned this morning, and talked about ways that we can move from just saying someone's going to call social work to thinking in our clinical team, what can we do? How can we provide a list of resources? Because guess what? Social workers aren't always available on the weekends, and as hospitals have cuts, fewer and fewer social workers are available. And so figuring out how to give our clinical teams resources and information to be able to document, hey, I'm going to link my patient to this resource, I'm going to use findhelp.org, and then I'm going to have someone following up to make sure that patient gets that and really closing the loop to make sure our patients get the resources. We worked on standardizing postpartum safety. There's a lot of talk earlier about, as we see in our maternal mortality review committee, the number of maternal deaths that happen in the postpartum period. This is another area that's really important to our MMRC and important to our patient partners. It's really thinking about early warning signs, how to reach out and where to call with that information, talking about how to make sure we're listening to patients when they call, and scheduling early postpartum visits. So all patients go home with a 2-week postpartum visit for a maternal health safety check at 2 weeks and not just wait for that 6-week visit. We worked on engaging patients and community members. This is a real cornerstone of the work that we're doing, and really thinking about getting those patient partners on our quality improvement teams. But then I'll talk about some other ways that we really work on getting patient voices in front of our doctors and nurses as well, to really improve and think about how do we improve care for all of our patients. We worked on implicit bias and respectful care training for providers, nurses, and other staff, and really thinking about what does that look like to improve respectful care on our units. How do we understand where bias exists, and how do we address that? And then finally, working on sharing respectful care practices and surveying patients on their care experience. So we talked a lot about active implementation of respectful care, and I'll show you a little bit about what that looks like. And then how do we ask patients, how did we do? Did we provide respectful care? How can we do better? And we've also done a ton of work on linking to community-based doulas and home visiting programs, and really thinking about how we really link our patients and provide bridges between the work we're doing in the hospital and all this awesome work that's happening in our community. Because there's so much great work that's happening, but as clinical providers, we kind of have our heads down, doing the work, taking care of the patients, and we're not doing all we can to figure out what are those resources in the community and how do we reach out and create partnerships so we can better care for our patients together. So just some of the resources we use to do this work. Engage and educate providers and nurses. We used a lot of like the Aftershock, a Laboring with Hope documentary. We provided that streaming to all of our labor and delivery units, and they did a lot of small group discussions. They used diversity science e-modules. We partnered with PQI, Speak Up Against Racism. We use the Hear Her stories. If anyone hasn't gone on the CDC website and pulled up some of those Hear Her stories, those are really great videos to put into grand rounds or put into nursing trainings. I really recommend you use those. Toxics is another really great movie that you can screen and then do a discussion on your labor and delivery unit. We found the small group discussions really made a difference in having these important discussions with our docs and nurses. This is what it looked like getting our docs and nurses trained across the state. Social determinants of health screening and linking to community resources. We pulled a random sample of 10 charts per month at all birthing hospitals in the state and asked them to document whether they were screening for social determinants of health and then whether they were linking to resources for patients who screened positive. On the left is getting the screening done, which our hospital teams did an amazing job. We're now sustaining around 80-90% of patients being screened for social determinants of health when they arrive on labor and delivery units. And then you can see the linkage to community resources. We've made progress, but we're still not there. One of the things we're really working on is this linkage with community partners, finding points of access. Do you know who your community-based doulas are, who you might have access to with your patients? Do you know if you have a home visiting program that works with patients? What are the resources in your community? And how does your labor and delivery unit do a better job of welcoming them in? We've done meet and greets with doulas, bringing them onto our labor and delivery unit, figuring out who our home visiting programs are and asking them to come onto our unit and giving a presentation. We worked on sharing respectful care strategies. This is one of our, we ask our teams when they're implementing strategies to either every month say red, we haven't started working on it yet, yellow, we are working on it, and green, we have it in place. And this is our hospitals getting their respectful care strategies. We created 13 respectful care strategies with focus groups of women of color around our state. And these 13 respectful care strategies have been posted on labor and delivery units across Illinois. So now we have 84% of hospitals have now posted these respectful care strategies and shared them with their clinical team members. And now we're working on doing PREM surveys to ask, here are the respectful care practices you should receive when you come to our labor and delivery unit, and then we're going to ask you before you go home to complete this survey to tell us how we did on giving you that respectful care. And we found that that helps move from our docs and nurses just saying, yeah, I provide respectful care, to really being like, no, what are these strategies? What am I supposed to be doing? What does it mean to commit to sit and talk to my patient? What does it mean to do active listening? What does it mean to introduce myself to the patient and her support persons every time I walk into a room? What do those respectful care strategies look like? And are we doing a good enough job? These are those strategies. Treating you with the dignity and respect through your hospital stay, introducing ourselves and our role on your care team to you and your support person upon entering a room, learning your goals for delivery and postpartum. These 3 questions really resonated with our patient partners. What is important to you for labor and birth? What are your concerns regarding your birth experience, and how can we best support you? And just asking patients those questions, sitting next to them at their bedside and asking those questions can go such a long way. Working to understand you and your background, your home life, your health history, communicating effectively across our healthcare team, partnering with you for all decisions so that you can make choices that are right for you, practicing active listening to ensure that you and your support persons are heard, valuing personal boundaries and respecting your dignity and modesty at all times, recognizing that your prior experiences with healthcare may affect how you feel during your birth, making sure you are discharged after delivery with an understanding of postpartum warning signs, ensuring you are discharged with the skills, support, and resources you need to care for yourself and your baby, protecting your privacy, and being ready to hear any concerns or ways we can improve your care. So we worked on those respectful care. We've now had over almost 9,000 surveys sent back to us from patients talking about their respectful care experience across 75 hospitals. And on the right, what this is showing that we've been able to reduce the disparity gap on respectful care and improve respectful care across the board. This question, do you feel pressured in accepting care I did not want or did not understand? When we started working on this, 17% of Black patients felt that way compared to 12% of white patients. We also saw the gap green to purple was for our Medicaid versus our private insurance. And then the next on the right over is after 6 months of actively working on respectful care across all of our birthing hospitals, we were able to reduce that gap for all patients and make improvements, which we felt really satisfied with this idea that we can improve respectful care. One of the most important things I think our teams really took away is that improving respectful care requires shared decision making, and we said this mantra all the time, recognizing patients as the experts of their own experience so that we can improve active listening and empowering patients to make choices through accessible, non-judgmental communication using shared decision making. So really thinking about how do we constantly think about active listening and shared decision making and really recognizing patients as the experts of their own experience. And that has gone a long way to helping our teams think about how to implement respectful care. I'm going to move quickly through this last part so we can have time for questions. This is engaging patients and community and in their quality improvement work. Again, this is a hard thing to do. When we started out, only 4% of our hospital teams said that they were currently engaging patients or community in their quality improvement work. We're now at 62% of our hospital teams saying that they actively have a patient partner or in some way engaging their community, which is really, really exciting for us. Something that we've worked long and hard on. On the right are some of the resources you can find in our toolkits. On the left, what are you doing to expand doula access for patients at your hospital? So we have a lot of doula engagement work that we're doing. On the left is a document on how to engage and start working with a patient partner. And the front is it's called a celebration of respectful care. We've been working on implementing respectful care breakfasts on our labor and delivery units. We started with really focusing on patient partners on your quality improvement team and really making, how do we talk about getting patient partners on quality improvement teams? And then we've really started also thinking about how do we get patient voices in front of our doctors and nurses? Because if we're going to work on respectful care effectively, we want our docs and nurses to hear patient stories, just like we're doing in this room today. If we can get the folks who are on the front line sitting next to the patient to hear these stories. And so we've been doing respectful care breakfasts where we invite patients who've delivered in the last year at our hospitals to come in and have breakfast with our docs and nurses from labor and delivery unit. Everyone put a name tag on that has their first name on it, sit down and have breakfast together. It's amazing when you sit and eat with someone, it reduces hierarchy, it makes people feel like they can sit and have a conversation. And then we have a panel discussion about respectful care practices. Patients share their experiences and talk to us about how we can improve our care. It's been really powerful. Here's some pictures from some respectful care breakfasts from across the state. We've had over 30 respectful care breakfasts in Illinois so far. We just had one at my own unit, and we had over 70 doctors and nurses show up and heard from 12 different patients sharing their experiences about how we can improve care. Some of the stories were all the things that went well and how the little things that docs and nurses did that made such a difference. We had a patient who'd had a C-HIS talk about someone holding her hand as she rolled into the OR, and she really talked about how that made all the difference to her, having someone in her ear talking through everything that was going to happen, really narrating for her. And then we had someone else talk about experience they had that definitely should have been improved and how it could be improved. And I think a lot of people took away from that ways that they can really engage in respectful care beyond just shaking our head and saying, of course I provide respectful care, but really listening to what our patients need from us. So we heard from teams saying, hearing from community members allowed our clinical staff to have a better understanding of what respectful care means, able to share what the team had accomplished and hear feedback, open conversations about experiences, positive feedback, and constructive criticism, listening to community questions and suggestions and shared how we are working, hearing directly from patients about their care experience. So this is our progress we've made on respectful care on our birth equity work so far. On the left is our baseline, where we were when we started in terms of our strategies. And then on the right is where we are as of January. And we're really excited. I think we've hit 70% with all of our strategies, and we're almost there on engaging patients and community and quality improvement work. Our goal is to have every birthing hospital in the state have a patient partner, and every hospital in the state have a respectful care breakfast. And we are moving in that direction. Last, I want to show you what we've done on that NTSV section disparities work, because this work went hand in hand, promoting vaginal birth and really thinking about what we can do on birth equity. This is our infographic we made with our teams to really think about how do you take action on disparities? How do you move from just looking at the disparities in front of you and saying, how can we possibly make a change, to really breaking it down step by step to move to action, understanding your data, identifying where the disparities are, actively listening to our patients and community partners and our clinical teams to figure out how to move to change, and then engaging, educating, improving, and then really continuing to share that data back with your clinical team so that you can strive to make improvements. And this is what we were able to do in our NTSV C-section rates in our state. The pink is Black patients, the blue is white, the yellow is Hispanic, and we were able to reduce our disparity gap for NTSV C-sections, and we've been able to maintain that for the last year. So we really call stratify the data, identify the disparity, share stratified data with your clinical team so they see where the disparities are, and move to action. Engage your patients and community partners for input, expand access to doulas and midwives on your labor and delivery units, and then improve shared decision-making and respectful care. And we think those are the hearts of really taking action on disparities. no matter what you're facing on your unit. So how do we move to sustainability? How do we build that infrastructure for sustainable equity strategies? I'd ask that you think about how you can stratify data by race, ethnicity, insurance status, and review it regularly and take action. Are you sharing stratified data with your clinical staff and identifying steps to action? Engage community partners to improve linkage of patients to community resources. Can you actively link patients to community doulas and home visiting programs? And think about those kind of bridges you can build from your own staff to the community. And then establish ongoing patient and community input on QI strategies and respectful care to provide direct feedback to your clinical team. How can you use PREM surveys, respectful care breakfast, patient partners for ongoing feedback? So in summary, maternal mortality and unacceptable disparities need our urgent action. Listening to patients and communities tells us what changes are needed. Build collaboration and buy-in with clinical team members, patient community partners where you can to help make change happen faster, and consider how you can take action today. And I'll leave this with this quote from Helen Keller I like so much. Alone we can do so little, but together I think we can do so much. Thank you.